Yeah, thank you so much, and I'm grateful to AIOS for giving me this opportunity. I'm just going to talk about high pressure, high stakes, and I think all of us tend to keep feeling these, keep facing these kind of situations. The cataract as well as glaucoma. I mean, there's no proceeding for the slides are not moving. Okay, yeah. So we all face this kind of a double trouble where you have high IOP at the time of cataract planning, and we need to understand what to do with that. So glaucoma management is definitely a must along with the cataract surgery, because the optic nerve is at stake. So what does it depend on? Well, we need to keep in mind, slides are not moving. Okay, so it depends on the type of glaucoma, severity of glaucoma, and the angle. So these are the three things we need to keep in mind. Now let us look at what are the considerations. We have to see whether we are dealing with an open angle glaucoma or an angle closure glaucoma, whether the stage is mild, moderate or severe, and we definitely need to look at the angles ourselves, whether it is open or closed on gonioscopy. The cataract surgery has evolved from SICS to femto cataract surgery now, and similar way we have evolved from trabeculectomy to MIGS now. So I will not be speaking of trabeculectomy here, because that is something that we all know and have dealt with, and I'm sure cataract surgeons do not want to do it along with cataract surgery. So we are going to talk about the MIGS, which have high safety profile, minimal disruption of normal anatomy, and ab interno approach. The efficacy is quite moderate, although lower than TRAP, but at least 20% reduction in the intraocular pressure is what you can expect. It is easy to use for patients as well as physicians. So now when we have to look at which patients would require one thing is we need to understand there are different types of MIGS. One is the approach to enhance the outflow through the trabecular meshwork through Schlemm's canal, which we will be discussing today. The other approach is to augment uveoscleral pathway by different techniques. And the third one is to suppress the aqueous production by directly ablating the ciliary processes. Well, here we will limit to the angle approach or the trabecular meshwork approach. Now, angle surgery has been very common for children from the ages. In adults, it always have been a little question earlier because we don't have trabecular dysgenesis in adults, so whether it will work. But now we are pretty sure, and the whole world is moving towards MIGS. Here I'll be limiting myself to these three things, which can be easily done along with the cataract surgery. Well, the key indications of MIGS with cataract surgery are ocular hypertension, where the pressure does not come down with medication and you have to keep patient on multiple medications. Primary open angle glaucoma, where the pressure is more than 28, angles are clearly open, early to moderate glaucoma, and there are established disc and field changes. This is the most common indication for MIGS. Now, pseudo-exfoliation glaucoma and secondary glaucomas also it can be used in specific situations, but you do need open angles and early to moderate glaucoma. There are certain situations where certain kinds of MIGS can be used in angle closure glaucoma, provided the angle is not synically closed and it is after PI, again mild to moderate, not in severe situations. So now, important prerequisite for anybody who does MIGS is that you should be able to do an intraoperative, preoperative and postoperative gonioscopy to decide and follow your patient. There are certain difficulties when we move towards angle surgeries, say from cataract surgeries. There is some learning curve involved because you have to operate under high magnification, you have to work at an angle, your patient's head is in a different angle, microscope is in a different angle. So the ergonomics is little different when you operate than the cataract surgery. And you have to operate with the one hand holding gonioscope because you're looking at the angle. So largely most of the maneuvers involve one hand only. So those are the learning things that we have. For example, this is the change in working position. This is how we operate routinely when we sit for cataract and trap. And when you have to do the tilt for the microscope and the patient, this is how your elbow angle would be. So just notice the angle of my elbow, how much it has to extend when you have to work. Even if you do optimize the position of your ocular and other things, foot switch, table, still your elbow is not that same position as you work with the cataract. So you need to learn in that position, learn operating in that position. Then the Schlemm's canal, the magnification, you have to use very high because you're going to work on Schlemm's canal on any MIGS, and the largest diameter, meridional diameter also is less than 200 microns. So you have to be able to see that kind of a small structure, so you will need very high magnification. So generally when we operate phaco, we use 4 to 8x. For these procedures, we may have to go to 15 to 18x. So that is the learning curve there, because you need to have a limited field and very stable hand, so that you're not, any small movement will get very augmented when you are doing operating under high magnification. And there are lenses now which can be, self-retaining and you don't have to hold, but most of the lenses you use, one hand is used to hold the lens, so you have to be performing surgery with one hand. You have to use cohesive viscoelastic, you may need assistant to hold, stabilize the eye, and you need to make sure that there is no egress of viscoelastic, there is not much surface bleeding, so as to improve your visualization, because that's the key thing in any MIGS. Talking about iStent inject, well, this is a smallest implant that we have that can be put on human body, and it's a titanium implant. The outcomes have been reported to be more than 80%, with good cumulative survival of say 74%. Now these implants can be done along with a cataract surgery in mild to moderate glaucoma. I'll just take you through the technique. So you need some amount of some gonio lens, and this is the injector. This is to retract the sleeve, and the black button is to push the sleeve. This is a trocar on which these stents are injected, are held. Now after phacoemulsification, once you put the intraocular lens, and you put in pilocarpine to constrict the pupil, and now this is the position you are operating. Now you have to tilt the head away from you and the microscope towards you to optimize the position for angle visualization or to do intraoperative gonioscopy. The idea is that your eyes, oculars and the patient's angle has to be in one line, so that you can visualize the angle. So once you've shifted to that position, you can even mark on the microscope if you're not sure how much. So this is eye prism SX, so I'm going to focus on the angle. So you can see this is the clear and fast view of the angle. Once you achieve that, you go inside with an injector, retract the sleeve, and as you saw yesterday in the live surgery, you can just press the black button to deliver the eye stent there and come back. Then the second one has to go at 2 to 3 clock hours position. So you have to be at the trabecular meshwork, just dimple a little and press the button and come out. You can see both the eye stents implanted there. So this is what can be done after cataract surgery. If you put the trypan blue dye, you can even see the veins or outflow channels being prominent there. This is the post-operative picture showing eye stents in the angle in the same patient. That is in the OPD when you are looking at the post-operative gonioscopy, so as to see the position of the implants. Okay. Similarly, another surgery is Kahug dual blade. This is a novel blade which is created to produce the removal of trabecular meshwork. So now we saw a stenting of the angle. Now I'm going to tell you about the stripping of the angle. So you de-roof the Schlem's canal for 90 to 120 degrees using this specialized blade called Kahug dual blade. So the principle largely for focusing an intraoperative gonioscopy is the same. You can use any of the gonio lenses available. This is the blade that you see. It has a tip with 2 sharp blades so that it cuts the roof of the Schlem's canal, and a parallel strip you can remove. So once you see the angle, you indent the tip inside the Schlem's canal and then move horizontally downwards so as to take off that strip. You can see the stripping of the angle happening to this direction. Then I go back to the place where I started and then do it in the opposite direction so as to de-roof say 80 to 120 degree of the angle based on how much you have planned for a given patient. You can clearly see that white strip which is the inside of the Schlem's canal. Then you have to remove the strip of the trabecular meshwork so that it does not go and reattach there. Some kind of bleeding can happen in both eye stent as well as goniotomy. Just remove that, and post-operatively again you can see the cleft in the patient's eye when you examine post-operatively in the OPD. The third thing is the bang, that is a bent angle needle goniectomy. So you can use a 25 gauge needle which you can bend inwards to create a instrument like a KDB. It's a indigenous way of doing it when for patients who cannot afford. So with the needle you do the same thing. You strip the trabecular meshwork in one direction and then in the other direction. The strips that you produce here are not very refined because you're using a needle, not the glide, but it is good enough to create the effect, and you can remove that trabecular meshwork strip. So this is how these angle surgeries are done with the cataract surgery, and they're pretty simple to do, and you hardly spend 3-4 minutes after or 2 minutes extra than the cataract surgery. Post-operative care is more or less similar to the cataract situations. I do use pilocarpine for where I'm stripping the trabecular meshwork, but not for stenting the canal. The ocular antihypertensives are all stopped after the surgery. So after that you see how the pressures are behaving, and if you have to introduce, that can be done based on how the patient's pressures are responding. Follow-up is usually at day 1, 1 week, 1 month, and every 3-4 months, like for any glaucoma patient. Post-operative gonioscopy should be done to visualize the implant or see the cleft so as to understand whether your surgery is working or no. My experience is very little at this moment. In these cases, I have done these surgeries. That is 60% of them are open angles and rest are different ones. So the reduction that I have seen is significant. That is in 90% of the cases, almost 15 to 28%, with average pre-operative IOP 17.32 on 2 meds and post-operative IOP 12.48 on 0.48 meds. Follow-up of almost 5 months on an average and 22 months the longest. And the patients that required post-operative medications were largely the patients where I had done in pseudo-exfoliation glaucoma, secondary glaucomas or juvenile glaucomas. So that has been my experience. I would just conclude by saying that the mixed procedure do provide 25 to 30% intraocular pressure reduction with a minimal risk and faster recovery along with the cataract surgery. The flip side is that the angle surgeries may result in a limited IOP lowering. That means you cannot reduce the intraocular pressure below episcleral venous pressure. So in patients where you require pressure in the single digit, you cannot achieve by MIGS alone. You may have to supplement with the drops, or you may have to resort to trabeculectomy. I am not a big fan of goniotomy 360 degree because it does lead to 360 degree fibrosis and scar formation in the Schlemm's canal. However, it is definitely important for severe cases or advanced situations. So these conjunctival sparing surgeries are here to stay, and they're pretty safe. What I would want to say at the end, the choice of patients and appropriate indications are the key to success. So we need to keep in mind that you do it for the right patients. Thank you for your kind attention.
Thank you, Dr. Sushma. It's a nice presentation and a real advancement in the glaucoma surgery.
Thank you, sir.
Any question from the audience, please?
Yes, you can. Yeah. Yes, I have done.
Have you seen some complications in your this thing?
Yeah, the complications that I would have seen mainly, largely are hyphema, which are self-resolving, and it is not very significant that would be visually disturbing. So some patients do have, 1 millimeter, 2 millimeter hyphema, particularly where you are stripping the trabecular meshwork, but it is self-limiting.
Have you done any study in your institute, just cataract removal versus cataract removal with these things that you have done?
Well, not really a comparative study as such, but what I would want to say in that context, I always keep getting this question whether the cataract surgery itself is reducing the pressure or it is the mix. Well, cataract surgery does reduce the pressure for 2 to 3 millimeters in an open angle for a short duration, but not for a longer duration. And pressure reduction would be more in a situation where there is angle closure glaucoma or angle closure situation, which can be little longer lasting. Whereas these patients that we are talking about are largely open angle glaucoma patients, and we do have follow-up of almost 2.5 years now.
Because these have economic implications,
Yeah.
Devices, recently I think the iStent Infinity was also launched.
Yeah.
So they're very expensive.
Yeah.
And many of the patients that come, is it really worthwhile, ask them to pay more? And
Not really, sir. We have options for all the patients. You have simple things like bang also, which which costs just 20 rupees needle.
Bang has a very good apply. I don't know. I would not be very comfortable with
It is, I would say, sir, it is something like that. If
the duration of follow-up that you have.
bang, yeah, bang I started even before doing iStents and KDB.
What
So it's 2.5 years. Pressure drop is significant. I have got 20 to 25%, and actually out of my bank patients, only 1 or 2 which required more medication. None of the bank patients I have reoperated for TRAB yet. I started the mixed surgery by doing bang only initially, so as to learn intraoperative gonioscopy and see how the feel is, and subsequently started on that. So there are options for all socio-economic status, like how we have premium lenses, simple lenses, I would say. Thank you, sir.
Thank you very much.